Hello, welcome to the Potavirus podcast. So we are back, and today we have Dr. Saima Aslam from University of California, San Diego. So she is an MD, professor of medicine, and she leads IPATH, which many are familiar with, the Center for Innovative Phage Application and Therapeutics. So she's the clinical lead and has treated lots of patients with phage therapy over the years. And we're so excited to talk to her today about kind of just largely the getting at this question we have, which is what's holding back the phage therapy field? Why don't we have it on the shelves everywhere yet? What are really holding things back? And what does it feel like to be on the front lines where you're treating the patients? What's blocking you? So I'll pass it over to you, Saima, to just give a bit more background. We would love to hear about how you got to this point where you're involved in phage therapy.
Okay, yeah. Well, thank you very much for the introduction, and thank you also for having me on the podcast. So yes, I treated my first patient with phage therapy in 2017, which now in 2025 seems like a really long time ago.
Yeah.
But part of how I got into it is being at the right place at the right time. So UCSD or UC San Diego was where the first case of phage therapy in the U.S. was. So I think we're all aware of Tom's case, and Chip Schooley and Stephanie Strath. They really led that. But for me personally, I'm a transplant infectious disease physician. And within the transplant field in particular, we see a lot of multi drug resistance. And I think, more so than general ID. And so there is really a really big need for something new and something, that works for multi drug resistant infections. And so that's how I got into it. The first patient I treated was a lung transplant patient that had been in the ICU for over 8 months with just progressively, worse and worse Pseudomonas pneumonia and ventilator need. So we treated him successfully with phage, and eventually he walked out of the hospital. And that was something, we weren't sure was going to happen. So since then, I've, at least within UCSD, specifically, we've now treated 21 patients. And I've been involved in a number of other cases at other centers, both in the US as well as internationally. And then we kind of got into clinical trials as well. So at some point, I will talk more about that.
So I guess one of the things we usually ask after that is, so it's 2017, so I guess 7 or 8 years ago was your first case, and I know you've done several. So what do you think what do you wish you had known when you were doing your first case that you feel like you now know?
Well, we know a lot more in terms of serum neutralization of phage, and that was unknown then. The patient I treated was immunocompromised, but I don't know, if, and we treated him twice. So I don't know if serum neutralization played a role in terms of maybe slowing down response to treatment, and, why we needed a second course of phage rather than why was one course not enough. I think, we know more about phage in terms of some degree of pharmacokinetics. So when I first treated, we had no idea how much to give, how often to give. And so we were just treating it like an antibiotic and giving it every 8 hours. We weren't aware of what the concentration of phage should be. And so one of the treatment courses actually had pretty low PFU per ml, and that one we gave every 2 hours. So there was a lot of unknown and a lot of making up. But I think now we do know more in terms of how to dose phage and what perhaps is a good concentration of phage to use. I think when I first started, I was treating for weeks and weeks, and now I'm treating far less.
Hmm.
So yes, I think we have gained enough. And I also, I guess I didn't say earlier, when I started off, we were treating anything and everything in terms of this is highly drug resistant and it's failed phage therapy. But I think I have a clearer idea now, at least clinically, where I think phage would be beneficial rather than all comers.
Ah, I feel like this is a pattern. We also interviewed Gina Sa recently, and she also said that patient selection, rather than all comers, as you say, has been like one of the big changes. So how is that? How do you see that now, and what is your criteria when you're going to accept a patient for phage therapy?
So I think one of the things that's also changed in this time period, when we first started, it was very new. I mean, it still is. But at that time, there was a lot of interest in a number of academic groups and as well as industry to really prioritize patient treatment. So these compassionate use phage therapy programs. Now, with more awareness, there's definitely a lot of interest, everywhere. And the availability of phage that we can use for patients, I think now is very limited. And so initially, when you could think of, well, maybe this is a patient I would treat with phage and you would get phage a month later, now there is such a long backlog of cases that it takes more than 6 months, sometimes up to a year to get phage. So if it's going to take that long, then you want to take patients or select for patients that have infections that allow them, to keep living with it. So chronic infections like orthopedic or, bone and joint infections, recurrent UTIs is an area of interest of mine, or recurrent pneumonias, CF population, things like that.
Got it.
So, how much have you learned? So, I guess now when you get a patient who you think is a good candidate, do you is it a dose that you always use, or do you use different routes and doses depending on what the patient has?
Yes, I do use a lot of intravenous. So the majority of my experience, actually all of my patients, except maybe two, I've treated with intravenous phage. Some also have received nebulized. But in terms of what dose I use, I think most places are now using at least 10 to the ninth PFU per ml, or 10 to the 10th. The kind of patients I treat, and again, my focus is more transplant, tend to have systemic infections, and so I have used intravenous. Recently, I had a patient that actually had a very sort of rare kind of disorder called malakoplakia, and that's in which macrophages ingest an organism but are unable to kill it. So you develop this mass, like sort of almost like a cancerous lesion, but it's all infection.
Wow.
And so this was actually a kidney transplant with carbapenem-resistant E. coli malakoplakia, but he had a very large open abdominal wound and he had a huge abdominal mass that came from his kidney. So that patient I treated intravenously, plus topically, plus we actually injected the mass directly with phage as well. So I think, in terms of how we're giving it, it really depends on where that infection is. So certainly for orthopedic infections, I think locally applying it to the area of infection is key. And most places, would do local application to where the device infection is, as well as intravenous. But I've started using intravenous for sort of shorter and shorter cases because of the development of serum neutralization, though I don't know if that truly is playing a role or not in the
Mm-hmm.
outcome. Um, and perhaps that's why either a shorter course or more local application to site of infection, may also be effective. But I think these are also unknowns. I mean, we have cases, and this case did great, the one I just talked about, but we kind of hit it from everywhere because we don't know what was the best way to treat it.
Yeah, and then I guess, I mean, it's great for the patient, but I guess then it's one of those situations where you don't know which of any of those was the key one that could have been that all of them helped, and if you hadn't done any of them, but this is sort of like the maybe why we need to do animal models and clinical trials because, well, I don't have to explain this
I
to you,
agree.
but yeah, and I guess um, in terms of telling patients bad candidate, they're a bad candidate. I guess Jessica and I recently interviewed someone who was a patient, and I'm pretty sure he would advocate, like, well, why can't we just give everyone phages? I mean, he may or may not have a more optimistic view of whether the treatment of some of the people you turn down is likely to be effective. But I mean, I guess, is it really that you and other people don't have the resources and you have to sort of prioritize? Is it because you want the cases to be successful? How does that sort of break down? And what would it take so that we could just give phage to whoever?
So certainly availability is a big factor, right? That's a huge rate limiting factor, which makes us, prioritize or somewhat ration phage, right? So, but one of the things I have learned, there's been a lot of interest in using phage for multi-drug resistant pseudomonas cardiac device infections, so LVAD in particular, left ventricular assist devices. So these are devices that are implanted within the heart, unfortunately have a high rate of infection. And one of the things we see is pseudomonas recurrent bacteremias for weeks and months. And I've treated, we published recently a paper last year in which we describe 5 cases of this persistent recurrent pseudomonas bacteremia with a cardiac device treated, with various phages, and all of them failed. So that now, we do get those emails, and I see these patients in clinic too, but without having a single success in that, I don't think that's what we should be treating. So those patients I do decline, and maybe at some point we will have a treatment. But at the moment, it's not going to work. So I don't want to put a scarce resource into
Yeah.
something I know is not going to work. So that's sort of an easy no. For others, prioritizing also is all, dependent on phage availability, but also the kind of infection. So there's a lot more people working with Pseudomonas phages or Staph aureus and E. coli, less so with Klebsiella or other organisms. So I think that also plays a role in which we're like, well, maybe I can't help you today, but perhaps we reassess. The other thing I'm really trying to do is if there are clinical trials that a patient can go into, then we really recommend that, right? So in particular for cystic fibrosis, there's so many different clinical trials that I don't think we should be treating people on a compassionate use if there's a trial that they fit into. So for myself, also similar for recurrent UTIs, there's a locus study that's ongoing. I'm hoping to start an NIH-funded study for kidney transplant and recurrent UTIs over the next few months. So those people then I keep track of.
Yeah.
But I think the biggest limitation really is availability and the delay in getting it in terms of compassionate use. And I think and you said this, others have said it too, we want to try and get the best outcome possible. So yes, there's some degree of pre-selection there, because if we are using it for compassionate use, good outcomes help us get more funding for actually definitive studies.
Yeah.
So I think that's something we keep in mind. The other thing I've seen for a number of patients, this was especially true during COVID when there were a lot of patients on ventilators with drug-resistant Acinetobacter infections. Sometimes the MDR infection is really the tip of the iceberg, or it's more of a pointer that this patient is not going to do well. And they have many reasons why they're not going to do well, and treating that Acinetobacter is not going to change that. And that's true of many patients also. And so it's a hard news to deliver, but treating or eradicating the infection doesn't always, make the patient better. So I think understanding the clinical scenario is very important.
Yeah.
So,
Oh,
sorry.
sorry. Mine follows up on that, but
Okay.
yeah. Or just, I really want to know, like, who makes the phages that you use currently, or do you get them from a variety of sources?
So I work with everybody. So whoever can help a patient, we work with them. And so that includes, a number of academic collaborators. So Baylor College of Medicine or Taylor Labs in particular, Daria Van Tyne's lab in Pittsburgh, Graham Hatfull in Pittsburgh as well for mycobacterial infections, Texas A&M. I think these are people I worked most with, and then certainly industry. So that included the old days with APT. Let's see, Biomics I haven't, but Sniper Biome out of Europe is the patient I treated most recently.
Oh, cool.
Yeah, I'm trying to think who else.
And so,
And other Amplify again no longer exists, but the first few cases that I treated were actually with phage from Amplify.
All
okay.
right. They're now Armada, right?
They are now Armada, yes.
Yeah.
So Armada has a clinical trial, so we have patients enrolled in those, but we have not used their phage for
Yep.
compassionate use.
And so do you
Understood.
just send out an email to kind of whoever, is it kind of a mass email every time, like who can help us?
Not so much. I mean, it used to be mass emails, but now they're more targeted because we know, one person, for example, really has a lot of phages that are ready to go. So E. coli in particular with Baylor, or
Hmm.
Pseudomonas with Daria. I work with Texas A&M. We're working with Burkholderia phages as well, and so they've been wonderful for that, and
Okay,
Klebsiella.
cool.
And then, I think Dr. Hatfield's lab is the only one for M. abscessus phages. So combination there.
Okay, so it's like stratifying according to species these days.
Yes. Oh, and then UCI as well. I didn't mention. So
Oh
David
yeah.
Pride at UCSD, and then UCI, we've used like Stenotrophomonas phages.
Amazing.
I was just wondering, in the five LVAT cases, you said that you had phages that matched and could kill in vitro in the test tube, and then you said you didn't see the desired effect. Do you have any sense? Was it the phages not getting to the bugs? Was it that the phages can't kill in the body because the conditions are different? Do you have any idea of what was going on?
Yeah, so we did try to figure out the answer to that. So, we looked at things like was there surgical debridement or not, sort of clinical factors, but then also phage related and, phage organism related. So one of the issues with LVAD infections is these infections are very chronic. Um, most of these patients had them for months. Um, because of a variety of antibiotic pressures over time, the Pseudomonas biofilm on these phages has a variety of different isolates. So every time when they are bacteremic and we get an organism, that organism is not reflective of that biofilm, right? It's just reflective of the tip.
I see,
And
right.
so, and so, to me, I think that's a big problem. The other, in vitro, when we have biofilm experiments, generally it's like a 24-hour or 48-hour biofilm, and we use phage, and it's great. But that's not true of people with months long of complex, biofilm communities. So to me, I think that's probably one of the reasons. So that's one. I do think it gets to where it needs to be because these are intravascular infections. Two of my patients, and I was talking to somebody actually at a meeting recently for a very similar patient they had in which it didn't work either. That, I mean, two of those patients were not bacteremic when we started phage, but within 3 to 7 days developed bacteremia. One patient was septic shock. And I think part of that was release of organism from the biofilm. I think it's getting to where it needs to be. But I mean, so again, these are hypotheses. There may be other reasons why it doesn't work. I mean, we looked at antibiotic and phage synergy. Um, all the patients developed serum neutralization at around 2 weeks. So, I mean, was it that when we gave the IV phage after 2 weeks, it wasn't doing anything? I don't know the answer. And we
Yeah,
certainly had local phage application as well. And I do want to clarify. So there are case reports of um, of localized device infection without bacteremia, in which you apply local phage, and that's been successful. But with the bacteremia ones, I'm unaware of any success.
Do you have a good model, or are you incorporating biofilm assays into your phage susceptibility testing at all yet, or is anybody kind of modeling the biofilm well as you've seen, or what are you seeing?
Yeah, so I personally don't have a lab. So I work with people that have labs, and I am the clinical sort of piece of that. But yes, I mean, even the patients I talked about with the LVAD infections, not all of them, but at least three of those five, we had tested Pseudomonas, those phages specifically against biofilm and showed excellent reduction in biofilm.
Wow,
But again, those are not 1 year long biofilms,
got it.
but with early onset, yes. And I think most of us are aware of this, and for any, whether it's company or academic group in which we're trying to treat device infections,
Yeah,
people are checking, in vitro, like 96 well plates
yeah,
assays for biofilm activity.
yeah. Can anyone? This is kind of delving deep into this one thing, but just curious. The Is it possible to take some devices out of patients that have surgery? Maybe it's removed, it's not going to be there, and then use that like for phage research, like the actual valve or whatever it is device.
Yeah, I think it can be. That probably would be more possible in the setting of orthopedic infections. Um, Generally, though, like an orthopedic device or this LVAD, it would only come. I mean, the orthopedic may come out because we're switching out that joint and putting a new one in. So I think those for sure can be assessed for research purposes, and people have done that with sonication experiments, in patients infected hips taken out, for example. The LVADs, only come out basically after the patient passes away. So
Oh,
that's generally not doable.
got it.
Yeah.
Hmm.
But pacemakers, I think, is another area where that's something that can be looked at because those can be changed out when they're infected.
Yeah. My head is all at this because I've been thinking about this whole PO1 grant, which probably you have too, with the phage therapy assay development, and the need for better models. And I guess, like, do you need it? My question kind of is becoming like, how do we get a 1 year long biofilm in the lab, or like, is there a way to make one of those?
I mean, there are ways to wake them. You can get, so even for LVADs, for example, I've done some of these experiments in the distant past when I was a fellow. But you can actually, the companies can provide LVAD material, or I mean, so that all is very doable to do in vitro or even in
Okay,
animal implants.
cool. Okay.
Yeah. And that's true, I think, for most of these devices. I think, there's so much need for something other than antibiotics
Yeah.
that I think when you start making a list of who we should treat or what should I go after, there's a million different scenarios, right? Based on the organism and the infection. So I feel like for our early stage of where we are in phage research, we should pick sort of the lowest hanging fruit rather than the hardest ones to
Yeah.
go after, right?
Yes.
And then refine, what we know about phages and what we know about how they work clinically in that lowest hanging fruit. So, and different people may have different ideas of what that is, but I find the recurrent UTI to be, such a niche, because these, and again, it depends on what, population with UTIs, but it's very common. Patients generally are clinically well, so we're not worried about someone that's passing away from some underlying disease process. And because it's common, I think in terms of clinical trials, it should start that hard to enroll.
Mm-hmm.
So that's one. um, I mean, the orthopedic infections I feel like are very complicated. um, and for sure there's interest. I mean, there's a company, I think Faxium from France, that's doing a Staph aureus PJI study as well. But yeah, I think these are lower hanging ones. I know there's a lot of research in cystic fibrosis as well. I'm not a CF physician, and so I see it from more of the infectious disease perspective. But part of the persistence of those infections is also the underlying architecture of the lung. So I feel like if we're not fixing that, I'm not sure how long lasting an impact we'll see with phage. And perhaps the goal is reducing flares or reducing need for antibiotic. But we've had patients with not CF, but a similar disease called chronic bronchiectasis, in which, the Pseudomonas, it may be the problem at some point, but later in the disease, it's more a symptom of underlying disease rather than the Pseudomonas is causing the disease. And so I've treated several of these patients, but I haven't seen any benefit. And that's another one where I don't feel like we should be pushing compassionate use.
Mm-hmm.
I think there's a clinical trial, but I think by Armada or another company looking at that. So that probably would be more helpful. But again, if we can't change the disease, I'm not sure treating the infection will help the patient, or at least get what they want.
And so in those cases, um, I guess there's two things. When you say that the treatment hasn't helped, is that based on symptomatic improvement, or how well their lungs work? Are you also monitoring whether you're seeing CFU reduction? And are there cases where you see CFU reduction and it doesn't help the patient clinically?
So, yeah, I had recently a patient we treated last year actually. Um, I guess the other thing with compassionate use is they come to us when they're really sick, right? So it's not early
Right.
in the disease process. So this is somebody that's been on oxygen, supplemental oxygen for years, and now has pre-drug resistant Pseudomonas. So yes, treating the Pseudomonas and getting subsequent sputum cultures over time, we did see a reduction in CFU. We did not see eradication. Um, Symptomatically, the patient felt better for a little bit, but it's hard to tell if that's really they're truly better or they want to feel better and so they are sort of more of a a placebo effect. Um, but within after the end of phage, they were kind of back to where they were. It didn't really lead to any lasting reduction. We didn't eradicate the organism, and they kept on requiring oxygen, which I think they would have anyway, regardless of whether the Pseudomonas was there or not.
I have this hypothesis that, or a lot of times when I'm thinking like, what research is holding back the phage therapy field? And people want to point to scientific research questions that if only we answered that, like phage therapy would be totally happening. And I increasingly don't think that's where the bottleneck is. I think it's closer to, it's hard to get the resources to do the clinical trials because there's not really the economics of creating any antimicrobial company in the end. And these antibiotic companies go out of business. So why wouldn't phage companies, even if they make a great phage cocktail? So where do you see the kind of bottleneck on that spectrum? Or are there like still some technical research questions that really we do need to solve that's meaningfully holding things back?
So I think, it's multifactorial. I don't think there's any one thing. Sometimes I think in the early days in particular, I mean, we did start clinical trials that ended without any meaningful benefit. And I think that was a rush to move into clinical trials,
Hmm.
thinking of phage and of the clinical issue as a very sort of 2D straightforward issue, which
Yeah.
they aren't.
Hmm.
So I think, yes, there is a lack of resources, but the NIH has started putting money in it, right? So they funded a couple of clinical trials, and now we have these large center trials also coming out. Um, and there are a number of companies that have come and gone also within phage therapy. So I think we need to learn more about how they work best and to understand that the simple, it's not, I don't think we can use phage as this is equal to antibiotic and do such an in vitro study and say, okay, let's treat the patient.
Mm-hmm.
And there are a number of reasons for that. So I feel like we do need more in vitro, we do need more animal model stuff. That being said, there's a role for the compassionate use, and there's some areas where I think clearly we have enough information that we can do clinical trials, and that's sort of goes back to that UTI, a couple of trials in that setting. Um, I still, yeah, I don't think and I think it's also important to really understand the clinical scenario. So some of the companies I've seen start trials um, have done so because they know the phage piece really well, but they haven't really researched that clinical piece well.
Hmm.
And I think that's a big reason why some of these studies have failed.
Interesting.
And even though I've said UTI, I mean, there was a large study that was published from Europe, right, looking at prostate surgery and using phage in that setting.
Mm-hmm.
But I think clinically, to me, and this again, I don't mean to have any, I don't mean any negative things for other clinicians, but I feel like there needs to be greater collaboration between the phage research piece and the clinical piece because some of it doesn't match. So
Hmm.
that UTI for prostate, surgery, as a clinician, I could tell you just reading the trial protocol, like why would this work? It wouldn't,
Oh, interesting.
right? And it didn't. So
Hmm.
I think we need stronger collaboration between the two, and I think there's more of that happening now. Um, and that helps both sides understand the issue because unlike antibiotics, phages don't do indiscriminate killing, right? Which is sort of the easier straightforward thing. Phage is so much more specific. Yeah, so
Right.
I think we need greater collaboration between the clinical side and the in vitro or the basic science side for truly translational work.
Yep.
And so that I think is one issue, at least in terms of the clinical trials so far that have been done, and I think that is changing. Um, but the other thing is also going back to that picking lower hanging fruit. I think if we work collaboratively, if we can show it works in one thing, then we certainly will have a lot more money to figure out how it works in something else, right?
Okay.
So, yeah. And then it's more complicated than using an antibiotic to treat a patient because phage is so specific. There's a human response, the immune response to phage that we don't see with antibiotics. And I think these things play a role.
Yeah.
Yeah. Yeah, and I mean, I guess, yeah, I think you're absolutely spot on. I mean, having listened to in various forms companies talk about clinical trials they're thinking of, I think exactly what you said. You know, talking to the clinicians and getting really detailed ideas about which endpoints you're going to select um, is really paramount for success because obviously if you're going to do a 12-week trial you don't want to be picking an endpoint that your clinician will tell you, well, even when an antibiotic works really well, you don't really see that endpoint met very often until 24 weeks, and then you set up your phage, you're basically setting it up for failure.
Yes.
And I think that's something that sort of naively I didn't realize how important that was. And once you start thinking about it, it's kind of more obvious. But it's one of those things that I think a lot of phage companies they get so jazzed on their phage and you know how well it can kill and blah blah and not blah blah blah. All those things are really important,
Yeah.
but
Yes.
they get so excited with that they don't bother to think about you know what the clinicians would tell them about what's realistic and not. So I think that's it's great that I know you're working with a lot of phage biologists, and it's important that people sort of understand each other,
Yes.
understand what they can learn from each other.
Yes. So I think, that degree of mutual respect certainly is needed. I think it is there now. I don't know if it was there always, but we need to kind of collaborate on both sides of that equation, I think, and we are now. Yeah.
And without asking you to cast dispersions on anyone, I mean, I guess I'm just sort of I'm a little bit curious. There was a paper published by the group from Belgium recently with like 100 patients that they treated, and I'm sure you're familiar with that. And I mean, I guess without again casting dispersions, are there patients that you said, oh, I wouldn't have ever thought? I think they're treating people where it's not likely to be successful, or what was
I think,
your reaction to the
yeah, I haven't
patient
looked at it
list?
recently, but mine. So when I look back, or at least what I remember, a lot of it was respiratory infections, including otitis media stuff, and it said upper respiratory. Um, yeah, I don't think there was that much detail regarding patient clinical scenarios, but rather big syndromes. So
Hmm.
the otitis media type stuff, I think, is used more in Europe because it is freely available to treat, anything. But they certainly had cases of, bone and joint infections. I think they had bacteremias and things like that also. But the biggest chunk that I remember was upper respiratory, but I forget the exact percent.
That's interesting. So is it like um, that it's not so much the entire syndrome that might preclude phage from working in your prediction, but it would be more like case by case, like that patient in that scenario, like what level of resolution do you kind of need to see as a clinician to make to
I
gauge
think
whether
the
phage will work?
organism and the clinical syndrome. Yeah.
Okay, so you don't need like specific that patient type
As far as I
information.
know, which, we're all learning.
Yeah, totally.
Yeah. But I
Okay.
mean, for example, at our center, we have, very careful phage selection process. Oh, not phage, patient selection process for phage.
Yep.
And we've had really good success rates. It's a smaller number of patients, 21 thus far locally,
Yep.
and our outcomes are like 85% success rate. So the ones that didn't work are the ones I wouldn't treat anymore. So this
Yep.
would be the LVAD, bacteremias, and then chronic bronchiectasis as well. I don't think we can,
Hmm.
help patients when they're late stage. And
Got
so
it.
those were our biggest failures.
Okay.
So with the patients that, fortunately you had success with, um, were there other patients that were similar where you didn't treat them because you couldn't find phages?
So I have not looked at that systematically. I don't know. I mean, certainly for recurrent UTIs, there are patients. I mean, there were some that died where we were finding phages.
Mhm.
Because again, the population I look at was kidney transplant. So a UTI in them is not just, a bother. It can lead to sepsis and, all those other things. But there's certainly other patients that, if they make it through a year or so, they get better. So that happens. Or maybe we find an antibiotic we're going to keep them on for the next year and they're okay. So, but that's not something I've looked at systematically, but that is something. So, for example, the study that I'm planning to start, hopefully in a couple of months,
Exciting.
it is placebo controlled. So, it's recurrent UTIs and kidney transplant patients, and they're all female. That will do 2-to-1 randomization. So, 66% chance you get IV phage, 33% chance you get IV placebo. So, and the reason to do that is to see that natural progression. It's hard to look at historically, but if we are randomizing patients, to placebo versus phage, then hopefully some of these things that are inherent, that impact the outcome are equal in both
Mhm.
arms. But we'll see.
How many patients do you need to recruit for that, do you
33.
think?
It's small. It's a small study. It'll be cool. I'm excited about it.
And just sort of getting into the funding geekery, but as I recall, you're getting funded by the Kidney
Yeah,
Institute, right?
NIDDK.
For
Yes.
that, not NIAID. So Jessica interviewed me a while ago about NIAID and how funding, and one of the things I was saying is that it seems like other um, institutes are now also starting to get being willing to fund this.
Yes.
Did I mean, we talked a little bit about this, you and I, when you were applying, but how did you, did you find that the study section was receptive to the idea of phages? How did you
Well, part
find,
of the study section was, and part of the study section wasn't. They were very strong views,
yeah,
Oh,
either pro or against. But I guess NIDDK thought it's worth taking a chance on.
wow.
I mean, so recurrent, and we specifically focused on kidney transplant because one, all the studies that happen in ID, or a lot, in particular anything new, immunocompromised patients are always out of it. Because we assume they're going to have bad outcomes, and
Hmm.
and for some maybe they do. And recurrent UTIs and kidney transplant is a huge problem. People lose their kidneys because of recurrent infection, recurrent episodes of rejection, recurrent impact of pyelonephritis on the kidney tissue. So to have waited 10 years to get a kidney transplant and then you get recurrent UTIs and you lose it in 2 years is awful. It's just terrible. And so, and a lot of these people do very quickly. If you don't have recurrent UTIs, your kidney is good for the next 10 years. So it has a huge clinical impact. We may not necessarily see that whole, impact within this small pilot study, but I think they understood that this is a big problem. No one's really working on it. All the trials on recurrent UTIs are looking at antimicrobial stewardship. That's not helping the patient.
Wow.
So I think I made a very emphatic case that this is worth doing, um, and I strongly believe it is. So I guess they were interested. They're the kidney center, and they want the kidneys to be good.
Yeah.
yeah, yeah.
Yeah. That's great. So antibiotics don't work in that
So
population, is
they
it?
do. What happens is, so when a kidney transplant patient, and this I'm talking more about females, it's more common in women. Certainly men have it too. Um, Generally, when they have, for example, E. coli UTI, I can treat it and they'll get better. but they'll have another episode 2 months later.
Okay.
Usually the time between them getting sick and landing up in the ICU is very short. So we've had people die of pan-susceptible E. coli sepsis because they become sick so rapidly because their immune system's not working.
Okay.
We can keep treating the UTIs and it's all treatable for some patients, but then they keep each time they get a UTI, it's an insult to that kidney.
Okay.
So they're losing bits of kidney each time. Certainly, with recurrent treatment or recurrent antibiotics, there's a much higher rate of drug resistance. So ESBL, for example, is very common. And in particular, when you look at different centers, so percentage population of ESBL among their kidney population, it can be anywhere from 40 to 80%. So then you have recurrent UTI patients in which all you can treat them with is an IV antibiotic. So I actually now keep ertapenem in my clinic because you can give it intramuscularly. During COVID, I had a lady who had a PICC line for 2 years, and she had a bag of ertapenem in her fridge, so that when she had a UTI, I told her to start because our hospital was full. There's no
Wow.
place for her to come in. So there are multiple reasons of why it's sort of a big bad problem. So I think, and I'm hoping phage works. I don't know it will, but that's our goal.
And do you think phage will lead to less problems with recurrence, or do you have reason to believe that?
So I've treated, and this is a very small n, I've treated 3 patients with recurrent UTIs due to 2 of them had ESBL E. coli, 1 had ESBL Klebsiella, with a UTI frequency of almost 1 a month for a couple of them. And so all 3, when I treated them with phage, all 3 I treated when they were not sick. So there's some data showing, the E. coli that we carry in our gut is what's causing the infections. And all of them had, very targeted, they had ESBLs. So we targeted the ESBLs and treated, 3 of these when they're asymptomatic. So we're really treating their carriage, right, or their colonization.
Oh.
And all 3 of them went a year at least out afterwards with no recurrence.
Wow.
And when one of them finally did have a UTI, it was not the ESBL we targeted.
Wow.
So it was pretty dramatic.
Yeah.
And again, these are pre-selected patients.
Yeah.
And again, that's why we're doing placebo-controlled, right? So maybe those 3 are not the norm. I don't know, but I think it's worth looking at, and that's where the money is needed, right? So I mean, some things is one of those high risk, high rewards. If it works, this is amazing. If it doesn't, that's fine. We did a 30 trial, 30 patient trial. We know, and we move on. But without having that initial investment, you can't answer that question.
Yeah. So do you think every physician that's going to write a trial protocol for phage should have already treated like a bunch of patients compassionately for them to kind of be in a position to make these decisions?
I mean, I think whoever is writing that clinical trial protocol, yes, should be in close collaboration if they are not the person treating these patients.
Yeah. Yeah.
Right? Because then sort of the nitty gritty of how am I giving phage to this patient? How am I working with the pharmacy to make this happen? So my patients, they self-inject at home. I teach them how to do it. The NIH, that was a big hard pill for them to swallow. Well, how do you know they're giving themselves their medication if you're not seeing them every day? I'm a very strong proponent of sort of looking things from the patient perspective. To me, it didn't make sense that I have someone coming into an infusion center twice a day to give an IV they could do at home. So we had a workaround. We're going to do video visits with them and we'll see them give their IV. So we know it's done and they do it at home. So I think having the experience is helpful to design a trial that is, pragmatic. Some studies people think of, and they're thinking of the patients as sort of how they would treat, their lab animals, right? They're there to take lots of blood draws and all that kind of stuff and multiple visits. Those studies are hard to enroll for. I mean, patients all have their own lives too. So I think it's helpful to have somebody that works with patients and has worked with phage as part of that planning process. Yes.
Yeah. You want to take it to the future looking questions now, Joe?
Yeah, I guess this is sort of the point where we usually ask, where do you hope to be in 5 years? Where do you hope to be in 15 years? And is what might keep you from getting there, or what worries you about?
So, well, 5 years, I'm hoping everyone with a kidney transplant with recurrent UTIs can get phage, and it
Ooh,
takes care of their problem. I think that would be amazing. Um, and maybe in 10 years, we're doing bigger, definitive, phase 3 trials, or maybe it's not needed. So yeah, 5 years, I really am hopeful that at least for this one indication that I'm looking at, it's going to work and we're going to have it available to people. Greater than that, I mean, I'm also looking at working with the Cystic Fibrosis Foundation for developing burkholderia phage therapy for CF and lung transplant patients. So I think by then, I mean, 10 years is too far out. That probably is 5 years also that we're doing that study and maybe it's done. I think 10 to 15 years, I feel like by then either phage is available and it worked, or if it hasn't, then I'm not sure it's going to.
yeah.
So I feel like this coming decade,
Mm-hmm.
where we have enough knowledge to design good trials,
Yeah.
um, I personally think is going to, either it's going to make it, or if we have multiple failed trials, and that's the end of it.
Yeah. 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 I like that. Like a go, no go decision. And it really does feel like that's kind of like all the trials that have been completed and published, most of them seem like they failed for design reasons, not phage reasons necessarily, or they weren't a fair assessment of the phage itself. So we still don't have the answer, even though there have
Right.
been trials. So now, hopefully, we can get the next
But
batch
I
of
feel
trials
like,
to
yeah,
actually, like the design part is, yeah, go ahead.
I think people are really making that concerted effort. Like instead of it being a race of me first, it's more let's take a breath
Yeah,
and let's think this through before we get going. And I think that's the way to do it. We wanted to give it, our best chance of it working.
yeah,
Yeah, I think certainly companies are more and more appreciating that, you know, you don't want to get the reputation of having a failed trial because that's going to send the investors running for the hills.
So the recent PGI study that ended, um, it ended with zero enrollment. So it was failed because they couldn't enroll anyone because it was just too complicated and not pragmatic. So, and that's not necessarily shade on the phage, right? That's again
yeah,
sort of like
Right.
clinical trial design. Yeah.
yeah, yeah.
So I have a further question, and I think you and Gina and others have kicked around the idea of having sort of a U.S. depository of phages and trying to get, whatever the people that your usual suspects of where you get phages to, and and I guess I've had discussions, and maybe they're not really going to come to anything because now who knows what's going to happen with the NIH Clinical Center. But like, what would it be involved in that? Where could you imagine it being housed? And like, how much would it cost? um, for if the government was going to make an investment in that, or someone was going to give a chunk of change, what do you think would be involved in having a countrywide phage repository, sort of like what they have in Australia or something?
Yeah. So, I mean, I've tried getting funding for that a few different times. It hasn't happened.
Mm-hmm.
But because I think, as the compassionate use cases show, there is a certain population of patients that really do benefit from phage. Whether they're part of clinical trials or not, remains to be seen. So I think one, manufacturing is a big hurdle, right? So we need at least one manufacturing site for the country.
Mm-hmm.
If there are certain phages that have been used over and over again in patients and we know they work, so it'd be great to have these set up. I think it's helpful to just have a few sites where phage is given, so patients can travel to such a site and get phage therapy, and obviously in different parts of the country, so it's not hard to get to. But that way, those centers have and develop further expertise in the clinical application of it. But then we get away with the current lag time of 6 months to a year.
Mhm.
In terms of cost, I mean, part of it is really the initial investment to set up a manufacturing facility. I think that's a big hurdle. The clinical piece of it really is not that expensive. So it's just, and I don't manufacture phage, so I don't want to give a number that's going to be
Okay.
erroneous and
No,
too
that's
low.
fine. Um,
But yeah, but I think, if we had a couple of well-to-do donors, I
Mhm.
feel like something could be done.
Yeah.
yeah, I mean, well, before we started this interview, I mentioned I was in Pittsburgh and I was talking to Daria a little bit about this. And I did have some conversations at some point about, I think, introducing you and Gina to some of the people I know at the NIH Clinical Center, and they had some interest. Now, I don't know what. Obviously, right now we don't know what, if anything, they'll be able to do. Um, but there was some interest, and I guess I'm wondering if we should try to like convene a meeting of the minds and
That
see.
would be wonderful because I think there are people that benefit. And all of our centers, we see these case reports. Um, and all these other countries have managed to do this. So it's kind of sad that we don't have that in the US. And it's sort of each center for themselves.
Right.
Um, but there's a better way to do it, right?
Mhm.
Yeah. I mean, I know with some of the companies, they have some concern that if their phages are used compassionately and, you know, there were some safety signal that they're worried that their clinical trial will be put on hold. And, it's not that they don't want to help people, but, obviously that's a potential issue.
Yeah, no, I understand that. But I think, within, for example, we have all these different labs, right? You mentioned area, there's Taylor Labs, Stanford, UCSD, all these places, or Mayo. I mean, I think there's a way that the academic labs can work together with a central manufacturing site.
Mhm. Mhm.
And that isn't, because they're doing that already, but they're doing that all, one on one, which slows things down. But I think if there's a funded central site where it's being manufactured and you have people that know what they're doing the treating part,
Mhm.
we probably could treat more patients,
Yeah.
maybe with better outcomes.
Yeah. Want to probably get to wrapping this up, but I just had a thought on your clinical trial that you've got going. So, do you have plans to spin that out into a company if it goes well? And do you think it'll be like a cocktail you're using on each patient that you might be able to land on, or it'll be kind of the individualized approach
So it's
coming
not
from?
an individualized approach. I'm working with Baylor College of Medicine,
Yeah,
so Anthony Moresso and his group.
awesome.
So the phages, so what we decided initially, we started off sort of individualizing, but we realized that three of their phages covered like 75% of my patients' isolates.
Wow.
And in terms of INDs and in terms of phage delivery and being efficient, it made sense to use that. So in the end, we decided to do a three-phage cocktail.
Okay.
So those three phages come from Anthony's lab. I know Baylor has formed a company, Phage,
Mm-hmm.
and so I mean, so yeah, so that's not me
Yep.
spinning off a company, but I think it's possible. Yes.
Cool. Awesome.
Yeah.
Yes, we interviewed the team at Phage. That one's not out yet. It's in my editing
Okay.
backlog, as this one
Okay.
will
Yeah.
join it. But I'll it'll be really cool to have, yeah, the perspectives beside each other. And this has been so enlightening. Thank you so much for being here and giving us a window into your side. I've got so many
Thank
little
you.
nuggets that I didn't have before. It's really cool.
Yeah, no, thank you for taking the time, and thank you as always. I mean, it's great. You clearly think so hard and carefully about these things, and it's credit to you. And well, it's just wonderful.
Thank you very much. It was a pleasure talking to both of you.
Yeah. See you around.
Yes.
All
Take
right,
care.
bye bye.
Bye bye.
Bye.